Okay, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, just wanted to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and guest speakers will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Okay, so next I would like to introduce you all to our guest speakers. Today joining us, we have Dr. Maureen Leonard. Dr. Leonard is the Clinical Director of the Center for Celiac Research and Treatment at Mass General Hospital for Children and Assistant Professor of Pediatrics at Harvard Medical School. She sees children and adults with gluten-related disorders, including celiac disease, non-celiac gluten sensitivity, dermatitis herpetiformis, and gluten ataxia. Joining us, we also have Dr. Stephanie Harshman. Dr. Harshman is a postdoctoral research fellow in neuroendocrinology at Mass General. She is also a clinical dietitian in the Center for Celiac Research and Treatment and in the Center for Feeding and Nutrition at Mass General Hospital for Children. They join us today to give a talk on the myths and facts of gluten-related disorders. So please join me in welcoming Drs. Leonard and Harshman.
Thank you. All right, I will share. Okay.
So I'll start. So just to introduce our talk again, we will be reviewing the myths and facts of gluten-related disorders. And our disclosures, as you can see here, they're listed. And our objectives today, so we'll go over the presentation of and diagnostic criteria for the two most common related gluten disorders, that is celiac disease and non-celiac gluten sensitivity. We will review the management of these two conditions, so how we treat, what are any major misconceptions, things like that. Then we'll highlight the hot topics and frequently asked questions related to gluten disorders. So is the prevalence really rising? Has gluten become more toxic? Is the gluten-free diet the only treatment for celiac disease? Should we all go gluten-free? And is sourdough bread okay for patients with celiac disease? These are just some of the questions that Dr. Leonard and myself experience in clinic. If you have any other ones, we will happily answer them through the chat feature. And at the end, we will introduce our research here that is taking place at MGH.
All right. So to get started, I want to make sure that everyone who attends our gluten-related disorders talk will leave knowing exactly what gluten is. So gluten is the protein found in wheat, rye, and barley. It's actually made up of two proteins, gliadin and glutenin. And when we talk about celiac disease, we're really focusing on the gliadin protein, which is the trigger of inflammation in celiac disease. So no one can completely digest gliadin, and this resistance to digestion leads to the ability of some peptides to sort of sit in the GI tract in the small intestine, and they can interact with cells there in order to eventually increase intestinal permeability and allow some of these long chains of peptides to interact with the immune system and cause a problem. So this is a particular protein that there's been a lot of research on, and several peptides within this protein have been studied and identified as sort of eliciting an immunologic response in patients with celiac disease. So for example, this red area has been shown to be particularly toxic to certain cells. This green area is an area that is known to cause some release of inflammatory chemicals. And the blue area is known to contribute to an increase in intestinal permeability. So it's a very complex and important protein. Moving on to the gluten-related disorders, there are many people that eat a gluten-free diet, and some of these people do so due to a medical necessity. And that's what we'll focus on, at least for the next couple of minutes, is those that are eating a gluten-free diet either due to wheat allergy, which is individuals when they ingest wheat have symptoms such as lip swelling or tongue swelling, hives, difficulty breathing, vomiting, and other symptoms. There are also patients with celiac disease, which is an autoimmune condition and a different immune-mediated response to gluten. And finally, there's gluten sensitivity, which is a disorder really characterized by symptoms that are associated with gluten ingestion. So I'm going to focus in more on celiac disease and gluten sensitivity, starting with celiac disease. So this is a chronic inflammatory autoimmune disorder that occurs in genetically predisposed individuals caused by the ingestion of the gluten-containing grains, wheat, rye, and barley. The ingestion of these grains leads to an inappropriate immune response, and that ultimately results in small intestinal damage. Patients with celiac disease can have gastrointestinal and extraintestinal manifestations that are common, and these symptoms can vary based on the age of the patient as well as how long they've had the disease. So for many years, and we'll talk about this later in one of our myths, but for many years, celiac disease was really considered a pediatric problem of the GI tract, where young children would present with symptoms like abdominal pain, diarrhea, vomiting, and weight loss. But today we really recognize celiac disease as a systemic autoimmune condition that can affect nearly any tissue or organ in the body. So celiac can still present with those gastrointestinal signs and symptoms at any age, but they can also present with other symptoms like anxiety and depression, joint pain, skin rash, or signs like anemia, osteoporosis, or infertility. Well, we have a fair understanding of the pathophysiology of celiac disease. We can't really say the same thing for non-celiac gluten sensitivity. This is a disorder in individuals in which the ingestion of the same gluten-containing grains causes the GI symptoms or the other symptoms. But in these patients, both wheat allergy and celiac disease have been ruled out, so they are not present. We think that this is quite prevalent, meaning it can be seen in 5 to 30% of individuals, but this is a little bit difficult because we don't have an objective test for making the diagnosis of non-celiac gluten sensitivity. We don't know exactly what the issue is with gluten. We don't know if it's that same protein, the gliadin, or something else in the gluten protein. And again, the testing, we don't have testing to make this diagnosis, but we do have to exclude celiac disease and wheat allergy as a problem. Once we do that, we can confirm a diagnosis of non-celiac gluten sensitivity clinically. And that means we take gluten out of the diet for these patients. And if symptoms resolve, then we try to put gluten back in the diet. And if symptoms again appear, then we make the diagnosis of non-celiac gluten sensitivity. So looking at sort of the various reactions to gluten, as I mentioned, celiac disease is an autoimmune condition, and these are all sort of immune-mediated condition. Because it's an autoimmune condition, this means that your immune system, or someone with celiac disease, their immune system confuses healthy cells in the body for foreign cells and sort of attacks them. So this takes some time to develop. Therefore, in most people with undiagnosed celiac disease, the physical reaction to gluten does not occur quickly once ingested, but it takes weeks and years for this process to build and cause symptoms. And that's very different than non-celiac gluten sensitivity, which is more of a response to gluten within hours or days, or for a patient with wheat allergy, who will have symptoms within minutes to hours. Now, this is true for patients with undiagnosed celiac disease. Once someone is diagnosed with celiac disease and on a gluten-free diet, we know that they can have symptoms related to gluten ingestion very quickly, within hours or days. We'll talk a little bit more about diagnosis in the next slide as well, but just to sort of start to look, it's very important that patients with celiac disease be eating gluten at the time that their testing is being done. So this is essential, or else the tests are not accurate. So there is an initial blood test for patients who are suspected of having celiac disease. And if one or more of those blood tests are positive, then we move forward with an outpatient procedure called an endoscopy, where small intestinal biopsies are taken, and we look for damage under the microscope that confirms the diagnosis of celiac disease. Again, as discussed for non-celiac gluten sensitivity, the diagnosis is made after confirming that celiac disease and wheat allergy are not present. And then that's confirmed again with putting gluten in and out of the diet to see if symptoms resolve and reappear. And finally, for a wheat allergy, there are several tests, including a skin test and an oral challenge that can confirm the diagnosis. So just taking another look at sort of some ways that we make a diagnosis of celiac disease or non-gluten sensitivity. It's a series of tests and dietary modifications and challenges. So when we have a diagnosis of celiac disease, or we're considering it, we start by doing some blood tests. If those blood tests are positive, then we are concerned about celiac disease. We do an endoscopy with biopsies, and we evaluate for whether celiac disease is present by looking for damage in the small intestine. If we don't have those positive blood tests, but a patient has symptoms with gluten ingestion, then we begin to suspect a non-celiac gluten sensitivity, and we'll do an gluten challenge, an oral gluten challenge. And again, these are sort of paired together because the symptoms are quite similar and overlap quite a bit, whereas wheat allergy, we're going to see very different symptoms, again, in terms of hives, lip swelling, can be some vomiting, a number of other symptoms. And so there are specific tests related to skin and oral tests that we would do there.
So the primary treatment for the management of celiac disease and non-celiac gluten sensitivity is to initiate and maintain the gluten-free diet. So what does that mean? When we are gluten-free, that means we avoid foods that have wheat, rye, barley. There are two derivatives from barley, that is malt and brewer's yeast, as well as oats. So even though oats, when we think of them, they might naturally be gluten-free, they are often harvested and processed in a way that they interact with wheat. So they have to be processed and sorted and tested and labeled gluten-free in order for them to be safe on the gluten-free diet. So for those that are practicing a gluten-free diet, you need to be very careful about what you eat and how foods are prepared. So thinking of common foods that have gluten, that's bread, baked goods, various pretzels, crackers, croutons, pizza, pasta, donuts, cakes, pastries, and cookies. All of these items, any food that is packaged will be required to have a food label, which most of us have seen. Those food labels are required to disclose any of the wheat compounds that you see listed at the top of this chart here in the ingredients list, as well as in the contains statement. So that is an allergy statement that is regulated by the FDA. If the food product has wheat in it in any of these forms, or the oats might, if they aren't processed in a gluten-free safe way, then contains wheat will be listed on the food label. What's interesting is when we think about packaged foods is we know that the ingredients list can sometimes be quite cumbersome, and it's hard to tease through many of those words. And Sometimes it can be overwhelming, or wheat might not necessarily be the first ingredient on the ingredients list. So you have to read again a little bit into the ingredients list. And other potential sources of gluten where we have to dig a little bit deeper into the food label includes chocolates, sweets, energy bars, imitation meats and seafoods, soup bases, sauces, and gravies. And then one other point to make is how risky shared cooking appliances can be. So when we think about these other potential sources, you can see that wheat is often used as a filler or a thickening agent in some cases. So you really have to be mindful of checking the food labels to see if an item is labeled gluten-free or not. If a food item has a GF on the label, that is a safe food for someone who is practicing the gluten-free diet to consume. If there isn't a GF on the food package, then you have to go to the label and check the ingredients list and the contains statement. If there's no wheat or any of its derivatives or relatives listed in the ingredients list, or and there's no wheat listed in the contains statement, then the food is safe for you to eat. There are a variety of foods that are naturally gluten-free. If we think about dairy products, fruits and vegetables, lean proteins, meats, fish, things like that. Again, those most likely will not be labeled gluten-free. A lot of those items also do not have food labels, but they are naturally gluten-free and safe for those practicing a gluten-free diet. So as with celiac disease, the common or the most practiced medical intervention for non-celiac gluten sensitivity is to avoid gluten. However, it is not generally necessary to maintain a strict gluten-free diet for as long as individuals with celiac disease, which it is a lifelong commitment. So there are some studies that show patients with non-celiac gluten sensitivity may be able to tolerate a small amount of gluten without developing symptoms. So that might mean after 1 or 2 years of a gluten-free diet, these patients can attempt to reintroduce small amounts of gluten. As I said, in contrast to celiac disease, a strict gluten-free diet is mandatory to stay healthy and manage the disease. So that's just something to be mindful of between the two different conditions. So now moving on to myth or fact, some of the hot topics in gluten-related disorders. Hopefully Dr. Leonard and I can crack some of these myths that we often hear and answer some of your questions as well. So the first one is that gluten has become more toxic. So as you can see here, wheat has been around for a very, very long time. And often we think since it's been around for so long, throughout the cultivation and domestication of wheat, that we have introduced so many genetic modifications into wheat that we see in foods now that it has actually become more toxic. And interestingly, when we look at wheat now, the protein content, which is the driver of inflammation, so the gluten content of wheat, of various different types of wheats from all over the Midwest in the US, varies on about a range of 3 to 4 percentage points from year to year. So a percentage of protein in wheat usually falls between 12 and 16%. And interestingly, when we look at these values, they have not changed since the late 1920s. So that's a pretty long time. And again, we have seen technology advance very quickly in the past few decades. So it's really interesting that the protein content has stayed about the same. So given all of these data, gluten is not more toxic, and gluten in wheat has not changed for over a century, despite the domestication and genetic modification that we have adapted to improved harvests, yields, prevent pests, things like that.
Okay, so I'll tackle the next myth, which is that the prevalence of celiac disease isn't really rising. We're just more aware of it now. So that's something that we hear a lot, and it's true that there are more accurate and available tests. So prior to the year 2000, prior to the 1980s, there really weren't accurate blood tests that were available to screen patients for celiac disease. And when those became available and able to be widely used, we could screen large populations of people. So that certainly has led to better recognition of celiac disease. However, we do have evidence that the incidence and prevalence of celiac disease is truly rising, both in Europe and the US, as well as other places. And so this isn't as surprising when you look at other autoimmune conditions like asthma, like type 1 diabetes, like multiple sclerosis, like Crohn's disease. All of these conditions have an increase in incidence, and yet we don't have better testing techniques for multiple sclerosis or type 1 diabetes. So this is evidence that indeed the incidence and prevalence of celiac disease is rising in line with other autoimmune conditions. We know that celiac disease is incredibly common. It affects 1 in 100 people. And over the past 50 years, we have a lot of evidence to show that this is increasing. So there's some studies to say that there's been a 4-fold increase in incidence between 1990 and 2011 in the UK. And then we have that this is true both for adults and for children, because there's been a nearly 3-fold increase in incidence in children between 2002 and 2014, which was shown by the Mayo Clinic. We also know that the prevalence is increasing. We have data that I'll show in a little more detail that shows that the prevalence increased 5-fold in adults over a 30-year period in the United States. And a more recent data looking at school-aged children in Italy has shown that the prevalence has increased by nearly 2-fold between 1995 and 2016 in children in Italy. So based on this data, the incidence and prevalence of celiac disease is rising and is expected to continue to rise. And that leads to another sort of fact that we want to make sure everyone's aware of, which is that celiac disease can develop at any age. So I previously mentioned that for many years, celiac disease was considered a pediatric gastrointestinal disorder, but it's just been since 2010 that we have evidence that celiac disease can develop at any age. And this was a study that followed 3,500 people over really a 35-year period, some for different periods of time within this time. And it showed that individuals can eat gluten for many years and they were testing negative for celiac disease. And eventually in this study, some tested positive for celiac disease, even in their 5th, 6th, and 7th decade. So that means that one can develop celiac disease at any age, and for some reason, people can tolerate gluten for many years in some cases before developing celiac disease. In other cases, we do know, and we have a research study that follows children at risk of celiac disease, and some children may develop celiac disease as young as 1 year of age or 1.5 years. So this is a mystery on why and what causes people to lose tolerance to gluten, but we can be sure that it can develop at any age. And just because you test negative at some point doesn't mean that you're going to test negative again several years later.
So there is another myth we want to kind of debunk: is sourdough bread safer for patients with celiac disease? So there is some literature that suggests that there's a specific bacteria in sourdough that have some gluten hydrolyzing activity. However, the gluten content of sourdough bread products does not reach the less than 20 parts per million threshold to be labeled as gluten-free or safe for individuals with celiac disease. So I saw there was a question in a chat related to wheat products in Europe versus the US, and we can answer that a little bit later. again, I kind of think this speaks a little bit to that. What are those foods that some people might report as fine for them? So some non-celiac gluten sensitivity individuals might be able to tolerate sourdough products, but it is not safe for patients with true celiac disease. But something interesting is gluten-free products are often not the most nutrient dense. So they are not, because their flours are not fortified with a variety of B vitamins, which was mandated like decades ago, requiring folate to be added to wheat flour to prevent to reduce the incidence of neural tube defects. We see that that doesn't happen in gluten-free products since we aren't using wheat as a base. But there are some really interesting new studies that have looked at ways to enrich these gluten-free products, specifically the use of insect-based protein powders to improve the antioxidant content and vitamin and protein content of gluten-free foods. So I encourage you to be open-minded about if you have a gluten-free diet or consider trying some of these foods. You never know, they might be good, and we might start seeing some of them on our grocery store shelves.
I'll wait for you to do the taste test.
I have had Cricket chocolate chip cookies before, and you cannot tell, I will say. But I'm not sure how popular they are. So the next myth we want to talk about is that people with celiac disease do not tolerate dairy. So often we see that in newly diagnosed celiac disease patients, that secondary lactose intolerance is common due to the loss of lactase, the enzyme that digests milk sugars that reside along the lining of the small intestine. So the damage that gluten causes in the small intestine is the main driver in the lack of lactase for people with celiac disease. So when someone starts to practice a strict gluten-free diet, the gut is able to heal, and the prevalence and the intestinal cells are able to produce and maintain that lactase enzyme, that brush border enzyme. And ultimately, lactose intolerance becomes a temporary period and improves as long as individuals maintain a strict gluten-free diet. And one more slide from me. So the next myth is that people tend to outgrow celiac disease. So as I've mentioned before, it's been demonstrated that patients with non-celiac gluten sensitivity may be able to tolerate small amounts of gluten without developing symptoms. So after an extended period of time where they are gluten-free, these individuals can start to reintroduce small amounts of gluten. However, when we look at celiac disease, you have to maintain a strict gluten-free diet, which is different than in the case of non-celiac gluten sensitivity. So for each individual, when it comes to non-celiac gluten sensitivity, the amount of gluten that someone can eat is completely based on the individual. It might be a bowl of pasta for someone. It might just be, a half a slice of toast for somebody else. So that is determined on an individual basis. The fact that it is not necessary to maintain a permanent gluten-free diet is the crucial difference to celiac disease, which requires strict lifelong maintenance of the gluten-free diet.
So this sort of ties nicely into our next myth, which are there are alternative treatments for celiac disease. So right now we all agree that the gluten-free diet is a lifelong commitment, but that could change in the next couple of decades. Currently, there are no approved treatments for celiac disease. You may see different treatment options available on the shelves, and these are just a representation of things that are available online. And these suggest that they can be helpful in digesting gluten or relieving symptoms related to gluten, but none of these treatments have been validated. So there's nothing available right now that can help patients with non-celiac gluten sensitivity or celiac disease other than symptomatic treatment of their symptoms that they have when they eat gluten. However, as I mentioned, that may change. There are now numerous sort of targets that have been identified as ways to help treat patients with celiac disease. And I've put just a few of the targets here and listed them for some of the potential strategies. But as I said, no one can completely digest gluten. So that's one area that people are looking into. Can we help digest that gliadin protein? Other programs are aimed at sort of blocking some of the steps that's related to gliadin's interaction with certain immune cells. Others that I'll go into more is trying to prevent the increase in intestinal permeability that's related to celiac disease when gluten is ingested. So there's a lot of potential areas here, and I'll just focus on two strategies that I think are particularly exciting for patients with celiac disease. So the first is the preventing the increased permeability induced by gliadin by inhibiting zonulin or inhibiting the increase in intestinal permeability. So there's a medication called larazotide acetate. It's a first-in-class tight junction regulator. This is a locally acting oral medication aimed at preventing the increased permeability that happens when somebody eats gluten. There is some interesting data that showed that patients with celiac disease who were on a gluten-free diet and received this medication had a decrease in symptoms compared to patients that were not on the medication. And so this is a medication that is the first medication for celiac disease ever to make it to a phase 3 trial. It's now been just about 2 years since the first patient was dosed for this treatment study. And I'm happy to say that MGH is one of the recruiting and participating centers for this trial. We're still recruiting subjects. And so towards the end of the talk, I'll let you know how to contact us if you'd like to hear more about the study and get involved. But I think this is a particularly exciting area because this could be an oral medication that could help protect against symptoms related to accidental gluten exposure. This medication is not currently looking at allowing patients to be able to eat gluten freely. And that's coming someday, and that's what others are looking at. But this is another area that is particularly interesting, I think, for patients with celiac disease, which is inducing tolerance to gluten. So there's a program that's using nanoparticles that actually contain the full-length gliadin protein, and the goal is trying to induce tolerance so patients with celiac disease could eat at least some gluten or tolerate accidental gluten without symptoms. This is great because some of the programs are looking at patients that have a specific genetic background, while this one would allow all patients with celiac disease to potentially benefit. The difference in this is that it's an IV administration. So that would require coming to the hospital and getting some of these nanoparticles in an effort to induce tolerance. There are some results that showed that there was a decrease in inflammation in the blood of patients with celiac disease who were eating gluten and exposed to this medication. But there's still a lot to learn here. We don't know how often somebody would need to come in for this. We don't know all of the side effects, and we don't yet know how much gluten could be tolerated, whether it's accidental or purposeful. But just having a list of all sorts of different therapeutic options under investigation is a very big change for patients with celiac disease. And it's very hopeful that there's going to be some options other than the gluten-free diet or in addition to the gluten-free diet in the future.
So another myth that I think we all hear often is we should all be gluten-free. And in the context of if you have celiac disease or diagnosed with celiac disease or have non-celiac gluten sensitivity, yes, a gluten-free diet might be necessary. For celiac disease, it is absolutely necessary. For non-celiac gluten sensitivity, it might be for a period of time, but you might be able to liberalize your diet. It has been an obvious push in health and wellness industries and in marketing worldwide, saying that we should consider eliminating gluten, which has driven the popularity of a gluten-free diet. And that may be related to the prevalence of non-celiac gluten sensitivity, but personally, when you eliminate foods from your diet, it can be very restrictive, and you should not eliminate something that you do not have to. Again, if you seek out medical support to see if you have non-celiac gluten sensitivity or celiac disease, then in the case, you may require a gluten-free diet. But for everybody else, having a well-rounded and balanced diet that does include gluten-containing foods is a healthy diet to continue with. And there's another fact that the gluten-free diet is not protective for heart health, brain function, nor does it improve exercise performance. So again, if there are these claims saying that is so beneficial, but actually it is not. So when you, it does not, is not associated with, as you can see here, a variety of studies, coronary heart disease. Actually, when we eliminate gluten, we actually reduce our consumption of whole grains, and that often reduces our fiber intake, which has been shown to be heart healthy and protective. There's also no relationship related to brain function or cognition. As you can see here, another study has shown no association with cognitive scores in middle-aged women without celiac disease. And there's really no recommendation for individuals to seek a gluten-free diet if you do not have celiac disease. You can also see here, there is no effect of short-term gluten-free diet on performance in athletes without celiac disease. So there is even more justification to not practice a gluten-free diet, and that you should have, if you do not have celiac disease or non-celiac gluten sensitivity, to have a well-balanced, fiber-full, wheat-containing diet. So how do you find out more? So within the Center for Celiac Research and Treatment, we are dedicated to improving the quality of life of patients with celiac disease and non-celiac gluten sensitivity, while we continue to learn the causes of the disease and look for cures in the greatest sense of the word, and more different treatment options. So we see children and adults with celiac disease and gluten-related disorders. In this handout, or in this slide here, we have various patient resources that are located on the MGH website. You'll be able to click through on the through that link. There's more information at massgeneral.org/children/celiac disease. And if you have any other questions, you can always email us at celiacresearch@mgh.harvard.edu with any other questions.
Before we get to questions, I did want to just highlight a little bit of our ongoing research. So we have many trials going on at the Celiac Center, many for adults and also for children. We have 2 ongoing clinical trials, one that I spoke about, which is the phase 3 study for patients with celiac disease and who still have symptoms. We're recruiting for that. We also have a study where we're aiming to identify new targets for treatments of celiac disease. And this, again, is for patients with celiac disease who are on a gluten-free diet and willing to ingest some gluten for the purposes of the trial. And then we are still recruiting for a prospective birth cohort study where we follow infants either before they're born or once they're less than 6 months of age through 5 or 10 years of age. These infants need to have a first-degree family member with celiac disease, and we collect some blood, stool, and some questionnaires. And the goal of this work is to try and figure out why some people lose tolerance to gluten at 1 year of age and others at 60 years. So we're trying to identify some factors that contribute to the development of celiac disease. And with that, we'll take questions, and I'll also let you know that we are available on all the social media, Twitter, Facebook, Instagram, and then we gave our email for you to reach out to. So look for us, and with that, I'll stop sharing so we can take some questions.
Thank you so much for a very helpful presentation. We are now approaching towards the end of the session, so if you have any questions, feel free to enter them in the chat box. Dr. Leonard, in the beginning, you had given some data. Can you explain the difference between incidence and prevalence?
Sure, that's a great question. So the incidence really refers to the new diagnoses of celiac disease that are occurring over time. And the prevalence really comes back to thinking about not only the new diagnoses, but the people living with the condition as well. So they're slightly different, which is why we talk about them a little bit differently.
Thank you. Any thoughts on why the incidence of celiac disease is rising?
So the fact that it's rising with other autoimmune conditions is concerning, and I think there's many that believe that this could be related to what's called the hygiene hypothesis, which is that as we've gotten better and better at treating infectious disease that years ago was, making us sick. Now, perhaps our bodies, because they're not fighting those infectious diseases, they're beginning to fight different parts in ourselves. So that could be, the intestine with celiac disease, the pancreas with type 1 diabetes. So this is something of great interest to us. So as I mentioned in one of the last slides, we're following 500 children that are at risk of celiac disease and trying to understand potentially, why it is increasing and what factors might be contributing. So we think that part of it may be related to changes in the intestinal microbiome or the bacteria living in the gut. And we want to understand how environmental factors like taking antibiotics or what kind of food we eat, or where we live, whether that's on a farm or in a city, how all of those things might change not only the bacteria living in our gut, but how our immune system develops. Mm-hmm. So you could have a whole nother talk on that question.
Thank you. So next we have plenty of questions related to nutrition.
Ready.
If a person were to eliminate wheat, rye, and barley for an extended period of time, perhaps for the benefit of other friends, family, eating together often, could they become gluten sensitive?
So I think that's a question Dr. Leonard can ask or can answer.
So again, if they're eating gluten-free, can they then become gluten sensitive?
Mm-hmm.
So I would say probably not, but that's a hard question because patients with celiac disease, their family members are at an increased risk of having celiac disease. Their risk, instead of 1%, like the general populations, it's closer to 10 or 25%, depending on their genetics. We also know that patients with celiac disease, their family members have an increased risk of having non-celiac gluten sensitivity. So an increased risk of having a problem with gluten. But I don't know whether patients that have non-celiac gluten sensitivity, if their family members have an increased risk of also having a problem with gluten. And it's been more difficult to do research in patients with non-celiac gluten sensitivity because we don't have any sort of blood test or objective measure to diagnose that. And so to diagnose that and do research studies, we need people with non-celiac gluten sensitivity to eat gluten, and that makes them sick. So it's very hard to do that kind of research, and that's why we probably have more answers related to celiac disease.
Sure. How long does it take to do non-celiac gluten sensitivity test? How long do you go gluten-free before reintroducing gluten?
Yep, so I think the literature suggests that, to help with symptom management, you have to maintain a gluten-free diet. For how long is up to the individual and their provider. Some of the literature states it can be, a year after maintaining a gluten-free diet to slowly introduce gluten. But again, that is variable. It is based on the individual and the discussions with your provider.
And it can be a little bit shorter too if you're still in that diagnostic phase. So it would depend on sort of how long it takes for your symptoms to go away. But I think sometime between 4 to 6 weeks on a gluten-free diet should be enough for your symptoms to go away. That should be more than enough with non-celiac gluten sensitivity for the majority of symptoms, and then you could bring it back in. But that's, again, a little bit difference between the, diagnosis versus later on, as Dr. Harshman suggested, we suggest returning to gluten every 6 to 12 months to see whether the problem with gluten is still there, since it can be transient.
Mm-hmm. Okay, so next we have a question about Cheerios. There is so much controversy around Cheerios. Many in the celiac world feel that these are not truly gluten-free despite the gluten-free label. What are your thoughts on that?
So I believe in the FDA's ability to regulate and invest in the food label. So in order for a food product to be labeled gluten-free, it has to be tested and demonstrate that it has less than 20 parts per million to receive the gluten-free label. However, there is a very small percentage of individuals with celiac disease who do not tolerate oats. And I think Dr. Leonard can speak to that a little bit more.
Yes, so there are two issues. One is, again, about 1% of patients with celiac disease can't tolerate oats. We did mention already in our presentation that for a patient with celiac disease to eat oats, they must be labeled gluten-free. Otherwise, regular oats may have cross-contamination that could make somebody with celiac disease sick. We hear a lot about the controversy related to Cheerios. In the past, we have, worked with them to talk to them about the practices, and it's a very different practice. There are certain oat companies that are purity protocol. They have, special ways of doing things to eliminate the possibility of cross contact. Cheerios is going a different way, an innovative approach to remove the potential cross contact from the Cheerios. I think we've discussed that means the way they do their testing, there's a potential for one box to have more than 20 parts per million. But so knowing that risk is something that everybody needs to consider. And patients with celiac disease and non-celiac gluten sensitivity understand that they're always taking risks. If they go to a restaurant or a friend's house, if they're not making their own food, unfortunately, there's a small risk. That's why we need medications to help patients with celiac disease, because they're taking risks every day. And so understanding that about Cheerios, you can make an informed decision if you think that there's a risk and if that's one you're willing to take.
Thank you. We have heard that in some European countries, due to the way they process flour, breads and pastas can be eaten by people with non-celiac gluten sensitivity. Is that true?
So from my perspective, I think it's more related to the different types of wheat that are commonly cultivated in the EU versus in the United States. So there's hard wheats, there's soft wheats, there's many different types. In the United States, most of the wheat that we cultivate and use are hard wheats, and they have a higher gluten content. In the EU, that's more softer wheats. Those have a lower gluten content. That's one thing to consider. The other thing to consider is in the European Union, they have different standards related to additives and preservatives in different food products. Where in the United States, like for example, if you're in Paris and you order a baguette, if you don't eat it by the end of the day, the next day it is like a crouton. In the United States, if you get a baguette, it's going to last like a week because we have compounds in there that help us maintain shelf stability and stuff like that. For individuals with that non-celiac gluten sensitivity, if they go to the EU and they're having some of those pastas that are made with some of those softer wheat flours, they are lower in gluten. So that might be something that they can tolerate more easily compared to the pastas and breads that are made in the United States. That is my perspective on that.
Thank you.
Yeah.
Can you discuss the overlap or lack thereof of the FODMAP diet for irritable bowel syndrome and gluten sensitivity?
Oh my gosh, loaded question. So the FODMAP diet is can be quite restrictive. It's given for individuals who are limiting these like fructo-oligosaccharides that are present in a variety of foods. It's often recommended for individuals with IBS. Sometimes for those individuals, we often recommend to remove gluten. Again, it's individual specific, it's symptom specific. And that is as much as I can say about that, because we can dig into the details about all of that. There is some overlap. Again, it's symptom specific and individual specific. Sometimes when you're on the FODMAP diet, if an individual is asked to eliminate gluten, sometimes they aren't. Again, it's all individual specific.
For someone who's not familiar with this, can you briefly explain in a few sentences what FODMAP means and what it is?
Yes, I can. So FODMAP is a fermentable oligosaccharide, oligo and di monosaccharide and polyols. See, a mouthful of so many things. And they are these long, different branching chains of starch molecules. And they're present in a variety of different foods. And they are thought to, when we eliminate those different compounds, these long, like branching different types of starches, it can help improve a variety of GI symptoms.
Thank you. And
find a dietitian who is amazing at irritable bowel. I am not one of those individuals. So there are many of them in the community where you can seek great guidance on if you feel like you need or want to learn more about the FODMAP diet.
And I went ahead and entered FODMAP. I spelled that out in the chat box if anyone's interested in learning more about that.
Fermentable oligo, di, mono, saccharides, polyols.
It's a mouthful.
Good luck. Yes, good luck.
Okay, so I've heard that people who follow a gluten-free diet develop an acquired gluten sensitivity. And if they incorporate gluten, they will have symptoms because they avoided gluten previously. Is there any truth to this?
We do see that patients who have celiac disease have been on a gluten-free diet and then are exposed to gluten accidentally, often have symptoms that are different than what they had at diagnosis. They may not have had symptoms at diagnosis, and so after gluten ingestion, they may have nausea, vomiting, diarrhea, or symptoms that are very different. We do see that. There was a recent study, I think about a year ago, that showed that that's related to the release of certain inflammatory chemicals, because otherwise it doesn't really fit with the pathophysiology of an autoimmune condition. How can somebody have vomiting within, an hour of eating gluten? But there is a rise in certain chemicals that leads to nausea and vomiting in patients with celiac disease. So at least we know that to be true for patients with celiac disease.
Thank you. I am told my celiac daughter likely has a milk protein allergy based on continued constipation and that her issue is not a lactose-related issue. Is there testing for this so that we can be sure?
I would say that we always want to, refer you back to your physician. And the first thing is, if symptoms aren't resolved with the gluten-free diet, then we always say, one, we want to be sure that it's the right diagnosis. And then two, we want to make sure that there's no gluten getting into the diet. And then three, that the celiac disease has healed. So I think the most important thing is making sure that celiac disease is diagnosed and treated correctly. Sometimes that means repeating an endoscopy to make sure the intestine has healed, and then sort of moving on if celiac disease is healed, then moving on and looking for other possibilities for symptoms.
Thank you. Wheat is a recognized allergen, but rye or barley are not. They will not appear in the allergy statement of packaged foods and can often appear by other names in the ingredient lists. There are also numerous products that claim to be gluten-free but are not certified to have below 20 parts per million of gluten. What is the current recommendation for how cautious to be with non-certified gluten-free packaged food? Do we know what level of gluten cross-contamination prevents intestinal healing? Thank you.
So you are correct. Rye and barley are not part of the allergen labeling statement. So that's the contains statement on a food label, which is why when we go through a nutrition education with someone, we encourage you to look at the ingredients list as well as the contains statement. So going through the ingredients list, looking for wheat, rye, barley, malt, and brewer's yeast, you have to be kind of a food detective when you go grocery shopping and when you start looking for packaged foods. With respect to the certified gluten-free and gluten-free labels, so any product that has a GF, a gluten-free label on the package, the FDA, they have to get, it mandates testing, and they have to meet the threshold of less than 20 parts per million in order to have the gluten-free label on the regular GF on the label. When something says certified gluten-free, there's additional testing that happens. In our clinic, we recommend that individuals can have gluten-free labeled food, certified gluten-free labeled food, naturally gluten-free food, because when we stick to certified gluten-free foods, it tends to be very restrictive. And that's not what regular eating should be like. We should have a variety of different foods in our diet. And there is another statement that we see on the labels. Often you find that one statement now where it says processed in a facility that also processes wheat, nuts, peanuts, other things like that. Those statements are not regulated at all. They are a disclosure statement of the individual manufacturers. Again, they are not regulated, so we cannot hold them to any kind of standard. So we tell individuals that if there is a food that is gluten, that might have no wheat, rye, barley, oats ingredients, has no wheat listed in the contain statement, but it has this maybe or is processed in a facility that also has wheat, we say that those foods are fine and safe for you to eat. Again, when we start eliminating all of these foods, it can be very restrictive. So we have to be mindful and just careful and a food detective when we go towards packaged foods. And I think Dr. Leonard can speak to the next level of gluten cross-contamination to prevent intestinal healing.
Yeah, so there was a study that showed 50 milligrams of gluten per day was enough to cause intestinal damage after 90 days. Some of the research that we do gives more, like that's half a gram. So in our research studies, we give between 3 grams and 10 grams of gluten a day to patients with celiac disease to study the immune system. And there is data to suggest if you're having 3 grams a day, which is like half a slice of bread usually, or maybe one small slice of bread, that you would have damage within 2 weeks. That is damage based on research studies. So when we have an endoscopy before you start eating the slice of bread and after, and then we compare the difference between how long your villi are. It's a lot harder we can't do that clinically. So that's why when we're asking patients to eat gluten, because we need to know if the diagnosis of celiac disease is correct or something like that, we have them do it for much longer because we don't have that pre and post measurement to share. But that's sort of like the general, 20 parts per million is safe. But I saw one other question that this can sort of relate to is somebody asked about whether, staying less than 10 parts per million may be helpful as well. So we say 20 parts per million, that's sort of the normal shaped bell curve, but we do have patients that even when eating gluten-free foods and less than 20 parts per million, they still have symptoms and damage. And so for that reason, we call those patients patients with non-responsive celiac disease, and they often need a special diet or a medication to help boost them into remission. So it's not, you know, there are nuances to some of this.
Thank you so much. Unfortunately, we are out of time for questions. Dr. Leonard, Dr. Harshman, thank you so much for a very helpful presentation. Any final thoughts you'd like to share with the audience before we end?
Eat lots of fruits and vegetables, which are naturally gluten-free.
And don't start a gluten-free diet before you've had testing for celiac disease.
Yes.
Thank you so much. And for those who are interested, this session is being recorded. If you're interested in viewing the recording, it will be up on the Blum Center website. I would give it about a couple of weeks, and feel free to visit us at massgeneral.org/Blum-Center. It will be posted there, and I'll also enter it in the chat box for those who are interested. Okay, so Dr. Harshman, Dr. Leonard, thank you so much again for a wonderful presentation. Thank you so much, everyone, for joining us today. Have a lovely rest of the day.
Thank you.